So welcome everybody. Hello. My name is Stephanie Poulton and I am a service lead for the City and Hackney COVID rehab service. So we see people with long COVID just in City and Hackney, and I'm a physiotherapist by background. And Melissa and I are here today representing all of the services covering the NEL area. Over to you, Melissa.
Hi everyone, thank you for joining. So I'm Melissa, I'm the clinical lead for the long COVID and pulmonary rehab services for Newham and Tower Hamlets. I'm the same as Stephanie, I'm a respiratory physio by background. So I hope that you will enjoy today's presentation. So I'll go over to Stephanie who will be starting.
Hopefully. Your screen is sharing. That looks good.
Yes, it is.
Excellent. Let me know if anything goes wrong and it stops or freezes or whatever. So to get us started, thought I'd just give a bit of background information really of sort of one of the frequent questions I get asked whenever I'm going to new meetings in different places with people outside of post-COVID world is long COVID still around? And there's an estimated prevalence of 1.9 million cases in the UK. This is according to the Office of National Statistics. There are some, I guess, inaccuracies potentially with these estimations because we don't have as much data on people who are experiencing infection with COVID-19 because we don't have the mandatory or freely available testing kits anymore, and the cases on a daily basis are not being reported, so it's kind of harder for us to keep track of the potential numbers across the UK. But of the 1.9 million that the ONS have identified, 1.5 million report day-to-day activities are adversely affected, so that's around 79%. And 20% of those report that their activities are limited a lot by symptoms of long COVID that they are experiencing. And just to give a bit of an idea of kind of how long it lasts, this is still a question that we're not able to confidently answer. And from the ONS data, again, around 4% said that they'd had their initial COVID-19 infection 12 weeks previously, 69% had had it a year previously, and 41% had it over 2 years previously. And this reflects what we're seeing in our services. So we are getting some newer referrals of people who've been infected, in the last 3, 4 to 6 months. But we are still also getting referrals from people who perhaps had their initial infection in 2021, 22, and are still unfortunately treating some people who first had their infection back in 2020. And so what does it kind of look like? Some of you might be really familiar with the signs and symptoms. You might have heard a lot in the press when it was spoken about in the early days of us realising that this was going on. And to just give you a bit of a snapshot of what we've been seeing through our services, you can see the bar graph shows some of the most common symptoms that we're seeing. So the most frequent symptom presenting is fatigue, followed closely by issues with concentrating and memory and breathlessness as well. But this is by no means exhaustive. You can see that there's over 200 plus symptoms that have actually been identified associated with long COVID, and there is some research supporting that these symptoms kind of cluster. There's different groups of symptoms that seem to appear together for certain patients. Something else that we found quite interesting for patients coming through our services is that on referral, around 67% are scoring with moderate to severe depression, which is really significant for a non kind of focused mental health service, and 42% with moderate to severe anxiety. And then on the right hand side here, there's some beautiful resources that have been produced by a collaboration with London South Bank University. These lovely posters that give a really full picture of people's experiences. It was co-produced with some people with lived experience of long COVID. There's a video, there is suggestions of how to communicate effectively what long COVID is, and that's a resource that we frequently give to our patients to communicate with employers, friends, family, other healthcare professionals. So something I definitely recommend looking up, and you can just Google LBSU long COVID and it should appear. So what's our setup in North East London? The Community of Practice website should give you some more detail about how to get in touch with our services and how to make referrals if that's something that you're not familiar with. But just to make everybody aware that there are services covering all of North East London. We have had some reports where patients are being told by healthcare professionals that the services have shut down. That's not the case. We are very much open and receiving referrals for the foreseeable future, and we'll communicate if anything changes. But there are 4 services, so one covering City and Hackney, the second covering Waltham Forest, the third here covering Barking, Havering and Redbridge, and then Tower Hamlets and Newham is the 4th service. And the other thing that we've all experienced is that around 38% of residents, we discovered in a Healthwatch report that was done in City and Hackney, do not know how to access specialist support for long COVID. And I'm not sure the figures amongst healthcare professionals in North East London, but it appears that there is also still some uncertainty as to whether there are specialist services. So we are very much up and running. We're trying to promote ourselves and send out information to the communities by voluntary sector organisations to encourage people to seek help if they need it. So please do help us to spread the word. And just to let you know that it is a really consistent offer in all of the places. So all of the services offer a multidisciplinary assessment. You can see in green the clinicians that are likely to be involved. There could be up to 5 clinicians involved in an assessment, depending on the complexity of somebody's presentation. And from the previous slide, you can see that there, with multiple symptoms and multiple systems affected, actually it might be appropriate to have people from different specialties involved in the assessment. But the average is that there would be 2 clinicians performing an assessment, and waiting times are less than 6 weeks across the services. Our rehabilitation packages might involve up to 5 clinicians, but the average appears to be around 3. Treatment sessions, the average is about 11, but the range is seen to be between 1 and 24 sessions. So it's not just a sort of an assessment and 1 or 2 follow-ups, which might be frequently the case in some outpatient services. Again, due to the multi-system and the complexity of some of the patients that we're seeing, we are seeing that there is a longer rehabilitation package that's required. And that duration of treatment, again, appears to be over a longer time, and that's consistent across North East London and also reflected from our conversations nationally. The average seems to be around 12 weeks that people are under a service, but it could be up to 36 months in a very small number of cases for the people who are not changing and much more impacted. And we're all doing community outreach, like I said, of joining up with voluntary sector organisations to try to reach some of the groups where there may be unmet need. And so over to you, actually, in the audience. I'd just like to invite you to participate. This is the sort of opportunity to just kind of hear your thoughts on, I wonder what you expected when you signed up for this webinar. So how well do people recover from long COVID? What do we mean by recovery? So go over to slido.com, type in that number, or take a photo on your smartphone of the QR code and type in what is it that we would mean by recovery. That's great. It's great to see that this is actually working. Yeah, so there's a couple here where it's sort of returning back to normal, returning back to baseline, so back to the level that they were functioning prior to their COVID infection. And then also on a sort of, I guess, a spectrum of that, a kind of sliding scale of that they're better than they were initially, able to function better. learning to cope better, so the impact is potentially lessened, getting back to being able to do things, and improved quality of life. So there's a few different ways of looking at it, isn't there? There's sort of the getting completely back to how they were pre-COVID. And then there's also this view of that they have skills and strategies to lessen the impact, to be able to do things that they want to be doing or need to be doing. But it might not necessarily mean that their symptoms have completely resolved. And it also might not mean that they are back to doing exactly what they were before. But certainly for patients coming in, I mean, everybody that we're seeing, understandably, wants to be back doing exactly what they were before. And it's a real challenge in the uncertainty of long COVID treatment and not really knowing what the prognosis potentially could be for some people, how to kind of manage people's expectations around that. Thank you for your participation. So what does the research say? The research within long COVID, I read an article where I thought really helpfully described the research as like a Swiss cheese. So there's lots of holes in it. There's lots of challenges. It's clearly a very, very, very new area for research. So we're just kind of 3 or so years down the line of it even being known about, heard about, a very, very new condition. And obviously it takes a lot of time to kind of get funding in place for research, to conduct the research, and then to get it out there into the public domain. And for the research studies that we're seeing so far, and they are increasing day by day, sadly there's heterogeneity between the populations that are being looked at. So some are looking at purely hospitalised patients, when actually our reality within our services is the majority were unwell in the community and not hospitalised. The sample sizes are small, and it's really difficult to sort of compare across the different clusters of the long COVID symptoms as well. So there are just 2 studies here that just give us a little bit of an indication of what the trends seem to be appearing. And this research is actually from countries outside of the UK. So again, there's a question mark of whether different countries have been affected in different ways with the prevalence of long COVID. So on the left-hand side here, one of the studies based in Zurich found that 23% of people infected did not recover by 6 months, and this decreased to 19% who didn't recover by 12 months, but it didn't decrease by much for those who didn't recover by 24 months. So they found that around 17% of people didn't recover by 24 months. So we're still exhibiting some ongoing symptoms that started after having the initial COVID-19 infection. This is also complicated by, there's going to be a mix of people who are vaccinated and unvaccinated, because the data was gathered in sort of 2021-22, when perhaps it was less likely for people to have been vaccinated prior to their infection. Of the 17% who did not recover by 24 months, an additional question was asked of them as to the trajectory of whether they're seeing recovery. And it's encouraging to hear that 68% had continued to recover over time, 13% saw an overall improvement over time, and around 5% had worsened, and 4% were experiencing a fluctuation of recovery and health impairment. So there is a trend for improvement that happens, but there is still a subset of people who are not showing improvement and continuing to experience symptoms over 2 years later. And another study in France showed that of people who were symptomatic at 2 months after their infection, that 85% of them were still symptomatic after 1 year. So moving on to our experiences as services within North East London. And we were talking together as a group about how helpful it could be to put some sort of unpolished data into this webinar. And I think the caveat here is to just take this with a a sort of large pinch of salt. So clearly we won't have been able to gather outcomes in a robust methodology in the same way that research would. So this applies to people who have successfully completed interventions and just kind of snapshots of interventions. So it might be just having seen one clinician, it might just be having gone through one group intervention from start to finish. But the trends here are really encouraging. With, you know, for work and social adjustment, here we're using the work and social adjustment scale, so validated outcome measures. In mood, it's the PHQ-9 and the GAD-7, and confidence was a sort of bespoke confidence rating scale. But you can see overall that we're seeing pretty good levels of some improvement. It doesn't necessarily mean a resolution of symptoms, because the work and social adjustment is very much about someone's participation with work and social activities. Mood may be a bit more related to symptomology, and then confidence reflects someone's ability to be able to manage their condition, whatever it might look like. And then going on to some more overall figures. So it's great to focus on the improvements, but also really key to kind of recognise that there are people who have stayed unchanged, and that there are a cohort of people who are reporting that their outcomes are worse. And another bespoke question, this is more aligned with an acceptance and commitment therapy approach of how to deal with long-term conditions. I'm just wondering, can you just check if you're on mute in the audience? And if anyone's not on mute, could you just mute yourself, because I can just hear an echo. Thank you. And with people's ability to do things that are important to them, so a very kind of values-focused approach to living vitally every day. Around 67% have reported much improvement, 22% improved a little, and around 11% seeing no change. And I'm going to hand over to Melissa now to give us a little bit of a breakdown for a case study, so taking you through somebody's journey with the service and what that has looked like.
Thank you, Stephanie. Can I just ask you to move on to the next slide when I say, or do you want me to take control? Yeah, great, thanks. So this is a case study that was seen on our service. So it was a 41-year-old man. He was married, had, I think, 2 children, I believe, and he contracted COVID in 2021. He worked for the NHS. He was admin staff, and he was working reduced hours because of the symptoms that he was presenting with. He couldn't fulfill his full contractual hours. He was also unable to help to look after his children as well. So there was a few things in his personal life as well as work life that he wasn't able to fully complete like before. So he was referred to our services. So usually referrals are made by GPs, and they referred into our services, and they complete the investigations prior to coming into our services based on their symptoms. So for this patient, he had severe breathlessness, fatigue, and heart palpitations. So prior to him coming to our services, he had a 12-lead ECG completed, a full set of blood tests, and a chest x-ray, but nothing abnormal was detected in those tests. So they referred to us with the assumption that actually he's suffering from long COVID symptoms. On assessment, so if we move on to the next slide, please, Stephanie, thanks. So when we assess, we use the Yorkshire Rehab tool, and that's the same for every service within NEL. And on that assessment, we found that the main points on assessment were still fatigue, breathlessness, and heart palpitations, which was the same as the referral. So we usually do our assessments over the telephone to begin with, and we make a collective clinical decision on what pathway the patient may be more which pathway would be more beneficial for the patient. So in this instance, we felt that the breathing clinic would be very beneficial for him, as well as the groups, because his fatigue wasn't significant enough for him to have one-to-one fatigue management, but we felt the virtual groups would be more beneficial in this instance. And I forgot, actually, one of the other symptoms he had was coughing as well, quite a significant one. And so when he came to breathing clinic, we actually conduct that face-to-face, because we want to identify whether he might have, in particular, breathing pattern disorder. But when we were assessing him, we did see he did have an abnormal breathing pattern, but it didn't seem suggestive of a respiratory origin. It was more of a cardiac origin, especially when we completed the exercise tolerance testing, completing his observations, his usual vital signs. We did provide exercises still, so normal nose breathing exercises in lying in the interim, but we felt that he still needed further investigation. So we took it back to the multidisciplinary team to discuss it, just to be 100% sure. And we felt that actually he did need some more investigations to exclude diagnosis. So we referred back to his GP, and they kindly sent him for 48-hour ECG. A 48-hour ECG first. We did recommend a cardiopulmonary exercise testing as well, but that was for the cardiology department to make that decision. So when he had his 48-hour ECG, the cardiology department actually ordered a CT scan as well as cardiopulmonary exercise testing, and the outcome for that was that actually he had several occluded coronary arteries, and he was scheduled for an angioplasty. And when he was scheduled for that, he was scheduled for it quite urgently, actually, because his symptoms were quite severe, very severe breathlessness, heart palpitations, and the coughing as well. He had his procedure. He came back to us and all of his symptoms were minimal. He lost weight as well. So that was a benefit for him as well, because actually prior to coming to us, he was playing a lot of football as well, so he was very active. So he was able to start some go into cardiac rehab and start exercising again. So it was a very good outcome for him, but it was a different scenario for this patient, because this highlighted a perspective of excluding diagnosis before considering long COVID symptoms as well. But it seems to me that actually COVID infection had exacerbated his pre-existing condition that he may have had, which he didn't show prior to COVID. And for his past medical history, he had no past medical history. So it was just a very interesting case, and how complex it can be, and how different parts of the multidisciplinary team can be involved in one case, and how important it is for us to have good communications with GPs as well to order further investigations. So the next case study is actually over to Stephanie, which was seen on her service.
Thanks, Melissa. And so this is a 41-year-old lady who had COVID in February 21 and was referred through to the service 16 months after that. In the meantime, she had also given birth to a baby, but being a mother of two, recognised that this fatigue and pain, breathlessness, difficulty focusing was very different to how she was feeling after she'd had her first child, and she'd been struggling working prior to being on maternity leave. So in her biopsychosocial assessment, the bloods, chest x-ray, everything was normal. She reported feeling frequently on edge, impatient, frustrated, low mood, had returned to work 2 days a week, but was struggling and reserved her energy for childcare and work rather than anything beyond like socializing. She was feeling isolated, had already had talking therapy support, which had helped a little. We agreed on a first treatment being the 8-week condition management program that we run. And through that, she received an introduction to the dysregulation model that we talk about. So the interaction between the autonomic nervous system, immune system, endocrine system, and how viruses can sometimes disrupt how those systems are operating. We have a model that we call balance, sustain, and nudge, and this helps people to recognise where they're at any particular time. So do they need to be pulling back on activity, getting their systems better into balance? Are they in a place where actually they've been able to maintain a level of activity and to sustain that for longer? Or are they in a place where actually their reserves have been built up and they're able to start nudging? We went through the concepts of the energy bank and talked about values. So using values rather than a sort of a goal focus of, for example, getting back to running or something. Actually, what is it that's important? What value is it that's important to someone as to why they want to get back to a particular activity? And that can help give some flexibility around what activity or what goal is then chosen. We used acceptance and commitment therapy tools, activity analysis, their mindfulness and self-compassion practices throughout the course, and exploration of how to go about making behaviour change. So after that 8-week programme, she reported struggling to put strategies from the group into practice and was still experiencing high levels of fatigue, stress and irritability with the challenges of prioritising her own health in the context of busy family life and trying to do 2 days back at work. And she opted for psychological support. She'd had some experience that was helpful in the past. And this is just a bit of a breakdown from the work she was doing with our cognitive behavioural therapy practitioner. And this is the classic CBT model looking at the 5 different areas. So in terms of thoughts, this is such a common experience that people report of having lots of concerns around, you know, what if others are doubting my symptoms? What if people think that I'm no good at my job? If others can't see that there's something that's wrong and they can't understand the situation I'm in, how will I manage people's expectations of me? And am I dealing with my symptoms in the right way? And understandably, you can see how that might leave someone feeling really anxious and frustrated. Her behaviours in this situation were to try to find answers. So there must be something that I could do to make myself feel better. She was pushing through, pretending that the symptoms weren't there and also hiding them from others. And her physical reactions included tension, that her mind goes blank, needing to move, feeling fidgety and twitchy. Mind goes blank twice. Look, you can see my mind obviously went blank as I was writing this. The loss of concentration. And then historically that she's always felt pressure of high expectations from parents growing up and high expectations of herself academically, worked hard for internal and external validation. And so the treatment approaches included raising awareness of the interconnection of those areas, so between thoughts and feelings, physical sensations and behaviours, adjusting rules for living and rigid expectations to promote flexibility when faced with challenges of debilitating symptoms, self-compassion also, so addressing some of those more self-critical thoughts, and behavioural change through behavioural experiments and mindfulness practices to be able to contact with the present moment and respond in different ways to the unpleasant physical experiences that she was experiencing, and to support her with developing non-judgmental and acceptance attitudes, which would again allow some present moment experiences, including her symptoms, rather than trying to escape these all the time. And so following this intervention, she was in the service for around 18 months. So having gone through the programme, there was a little bit of waiting time for the psychological input. And after 11 sessions of one-to-one input, she's still experiencing symptoms that are ongoing from long COVID, but there's less stress associated, and she was more able to make helpful choices that supported living well alongside long COVID. So this might be a fairly classic place at which we end up discharging people from services. So it's not that they are symptom free, but they're in a place where they're able to cope better with the symptoms that they're experiencing, and if there are fluctuations, to be able to make adaptations to cope with those changes. And so she talked about here, my responses to stressful and challenging events are more adaptive and balanced, and I feel proud of myself again. I'm able to savor the moments of connection with my family despite the challenges. I'm more able to notice worrying thoughts and show compassion for myself. And I'm not as swept along by the train of thoughts as I used to be. I have more choice. So sometimes it might be that on our outcome measures, we don't significantly see the reduction of symptoms, but we know from these more kind of patient narrative responses that there's been a significant shift for these patients, and particularly where this is more of a long-term situation for the people that we've been seeing. And back over to Mel for a further case study.
Thank you, Stephanie. So the final case study. So this one is a little bit different compared to the first one that I presented. So this is a 39-year-old female. She was single and she contracted COVID in 2021. She was a lawyer, but unfortunately was unable to go back to work because of the severity of her long COVID symptoms, and with that she was unable to look after herself, so actually moved back in with her parents. So on assessment, she was referred for severe fatigue, breathlessness and pain. If we move on to the next slide. So on assessment, as again, we use the same rehab tool to assess, and the main points that came from that was fatigue, breathlessness and pain. But she also had very severe anxiety and low mood as well. Before she was referred, it was her blood tests and chest x-ray showed nothing abnormal detected as well. So for this patient, she was very complex. She had a lot of symptoms which were overlapping, and it was very hard to pick which one was the main cause of everything else. And it involved the whole multidisciplinary team. The physios and occupational therapists were involved significantly. She was discussed on MDT meetings several times. And we found that it was becoming quite difficult because she was reluctant to actually address her severe anxiety and low mood, which was somewhat impacting on her recovery. And so we did the interventions. We referred her to breathing clinic as well as one-to-one fatigue management because her fatigue was very severe. And we felt that perhaps that the pain was actually altering her breathing pattern. But the breathing pattern was altering her breathing pattern, and the breathing pattern was then causing a very high respiratory rate, muscles to be very tightened, and then she was becoming very fatigued from that breathing pattern disorder, because with this patient she was actually breathing at a rate of 30 breaths per minute, and it's very high for a patient. So you can imagine how much your body's working to just breathe at that rate. And it was just causing a vicious cycle. So we gave breathing exercises in lying, and we gave her the tools, the energy conservation techniques for fatigue, but we felt that she kept relapsing, and actually her breathing pattern was getting worse and her fatigue was getting worse and her anxiety and low mood was getting worse as well. And we then altered the breathing exercises and decided to do it in sitting, because we found that actually it was triggering her for her to do it in lying, and we wasn't too aware of why it was triggering her. She wasn't fully telling us why that was the case, but we could see that her anxiety was becoming worse when she was doing the exercises in lying. So we changed that to sitting, but there was still very small improvements, and only until she addressed her mood and accepted Newham talking therapy help, that actually we started seeing a lot of changes in her physical symptoms, and her breathing pattern started to improve a lot. And this is just another complex case on how mental health can hinder the recovery, and how we need to be looking holistically at all of the treatment, and how many professionals can be involved at any one time in seeing one patient. And actually we saw this patient for over a year. So like Stephanie's previous case, she saw for 18 months, we saw this patient for a very long period of time, and there wasn't much improvement in that long period until quite the very end, when she finally addressed her mood. It takes a lot of work as well from healthcare professionals, and a lot from the patient to try and take control of their own health as well. And hopefully all of these case studies that we've presented to you today have showcased different aspects of recovery, and how we have to manage these cases holistically, and it can be quite complex on pinpointing on what the main issue is as well. I'll hand over to Stephanie, who'll be finishing off the presentations.
Thank you. And so just the final couple of things is just, I think what's been really helpful for all of us is gathering patient feedback and patient experiences. So here are some examples of patients giving feedback, talking about that, coming along to group intervention has had a really significant impact to connect with others, and has made a real impact in this person's everyday life. Also, learning models which describe the impact of long COVID on the body was really good, and using this as a foundation for strategies to manage my condition. And all of the sessions were hugely useful. And this person, before I started these long COVID sessions, I was in a very bad place. I find this has helped me to be able to deal with some of the issues I face whilst battling most days. And after attending the group sessions, I realised a change, not 100%, but I'm positive things will improve. So thinking back to that Slido where you were all contributing to what recovery looks like. So it could look a bit like Melissa presented, of a reduction in symptoms. And it also could look like people finding they're better able to do things in their everyday life, to manage their condition, and have increased confidence that they'd be able to cope, whatever the challenges might be. And then the final one here, I couldn't shorten this because I thought it was just such a rich reflection of this person's experience. I feel like I came into the programme in a crisis, and although I still have long COVID, I'm exiting in a really different place. I have learnt so much in the groups and in my one-to-one occupational therapy work. I've also been able to keep in touch with 3 people from the group on WhatsApp, and this has provided a type of peer support. I feel so lucky to have received the support to understand what's happening in my body and to meet my situation with acceptance and compassion. Long COVID can feel very unsafe, and I feel the support I've received from your service has been essential for creating the safety needed for recovery to begin. I also have to say that your support has also enabled me to manage my long-term anxiety and symptoms connected to trauma. Techniques such as mindfulness have been life-changing for me. I feel very aware that the journey ahead will probably not be straightforward in terms of health, and that's a bit scary. but I feel so much more able to manage it all. And it's also really helpful knowing that I can reach out to you for support in the future if I need to. I just feel full of gratitude for everything you have done, and I think you deserve an award for the work you do to support people with long COVID. Thank you. So just a couple of things to pull out from here, that where she talked about creating the safety needed for recovery to begin, as I mentioned earlier, it might well be that at the end of our intervention with people, actually that's the point that they feel their recovery may start. So they have the tools to create the environment to support their body for potential regulation and hopefully to see their symptoms improve. But it may well be that a lot of people leave our services at that stage. And then secondly, also to note that, you know, people coming in with long COVID, a lot of people have some pre-existing health conditions, whether it's relating to mental health or other conditions. And actually, this really holistic view that we take, as Melissa's talked about, the multidisciplinary team kind of teasing out the different aspects that might be drivers to, you know, precipitating ongoing symptoms and impact. This approach can be helpful to unpick things that may have also sort of predisposed somebody to long COVID or been something that gets in the way as a barrier for their potential improvement, whatever that may look like. So over to you, if anybody has any questions for us. We're really happy to answer. I think there's about 10 minutes left in the webinar time.
I've just seen a comment by Tossin, Starlane Medical Centre, I believe. She just said that I've seen a couple of patients who find it difficult to taste after COVID, which is affecting their mental well-being. So I'm not too sure what's available in Hackney, City of Hackney, Stephanie, but I know in Tower Hamlets and Newham, we're actually in discussions with the dietitian who could help with taste and smell. So it's worth checking to see if the dietitians can help in any way regarding this, Tossin, to see if you can refer, because yeah, there is a lot of patients who have affected taste and smell, and that's something dietitians can actually help with.
Yeah, and just something to add to that, is interesting because it's not one of the top symptoms that we're seeing with people. It was definitely something that was, you know, spoken about a lot in the media. And whether it's the situation where people can continue functioning on a daily basis, even though there's this loss of smell and taste or changes to smell and taste, and therefore they're not reaching us from a rehab point of view, is a possibility. And also that over time, for some people, that does resolve. For the people that we have seen, we tend to direct them to two websites, Absent and the Scent. I'll find the website addresses and I can put them in the chat as well. And also watch this space, because there may well be a specific smell clinic that gets set up to serve North East London. But if you're coming across people who are distressed by their loss of smell or taste, do refer them into our services, because we've got access to psychological support to help manage that distress as well, and we can guide them through the smell training websites. And there we go, Melissa's managed to find Absent and hopefully the fifth sense or scent, whichever one it is, fifth sense, I think. And we've got a question with a hand up. Go ahead, Patrick.
Hi there. Just a question about the respiratory clinic breathing referring to. Can I just ask if is that part of your service, or is that a separate service that you patients to?
So I'm guessing that's a question for me. So yeah, so that is actually part of our service. It's a pathway arm within the long COVID services, and it's run by the respiratory physios. They look primarily at breathing pattern disorder, but if they don't have it, they will still explore other reasons as to why the patient is feeling breathless. and they will treat if they can. If they can't, then they will refer back to the GP for further investigations or respiratory consultant, secondary care if applicable.
There is another question in the chat box saying from Laura, do you feedback to the GP practices when patients have been assessed discharged? I don't think we have been receiving anything.
Thanks, Laura. I think you're sitting Hackney Athena Medical Centre. So standardly, yes, you would usually, hopefully the GPs would receive something after patients have been assessed and after discharge. If someone's been under the service for a longer period of time, we would probably write some sort of update after, input for 6 months or something. If there's anyone in particular, Laura, that you want to hear about, please do email us. I'll put the email address in the chat here, and I can follow it up for you, and we'll find out what's happened there. But hopefully that's just a minor blip, but standardly we aim to communicate back to the referrer. But also, if the referrer is not the GP, we would always copy the GP in so that the GP is aware of the result of the assessments and intervention. Melissa, I don't know if you want to say anything about what happens in Tower Hamlets and Newham as well.
Yeah, same. Tower Hamlets and Newham, we do send out the discharge letters to GPs as well. So it'll be addressed to the patient, but we'll CC the GP into there, and usually we send it electronically. So hopefully they should be receiving it as well. But please do get in contact if there is patients that you haven't heard about.
Yeah, and I think I just reiterate that as well, like all of the contact details for the NEL services are on the Community of Practice Hub, which I'm sure you'll know where they are because you registered for this webinar. So all of the services are really keen to receive correspondence from anybody, inquiring whether a patient's suitable, if you want to follow up how somebody's been doing, or just talk us through about anybody that you've been struggling with specifically. We're really, really open for a multidisciplinary approach because there's a lot of complexity to unpick. So please do get in touch at any point. Yeah, Patrick, is that new hands?
Yes, it is. Hi, Stephanie. Sorry. Another question. You mentioned in your presentation about acceptance, and you referred to how sometimes the patient's journey of recovery may not actually begin until they actually leave the service, and accept probably a big part of that and taking ownership. How do you guide or navigate patients or lead patients to that point of acceptance? Because many patients might come to our service wanting a cure or something done rather than maybe trying some of the methods and taking it upon themselves. So how do you guide them? Is it through the mental health service, talking therapies, stuff like that, or is it through education in your own team?
Yeah, thanks, Patrick. That is a big question, isn't it? It's like $1 million question of how do we do this? Definitely not a recipe of a one size fits all. The approach that we take in our service is it's definitely a process. It takes time, and when people are arriving and they're saying what they want to get back to doing, that's not the place to challenge that. It's the place to listen and to hear and to kind of let them know what it is that we are offering and are they willing to work with us. And then through a process of kind of raising insight with them, hopefully they'll come to a realization at some point that where they were hoping they might be getting back to running 10Ks or something in a month's time, actually that's not the place that they're in right now. It's not that it's never, but it's just not right now. All of our physios and OTs and anybody else that we have in the service, speech and language therapists as well, we're all trained in acceptance and commitment therapy. So we've done kind of introductory psychological courses, and so we all talk a very similar language. So the more physical therapists can do a superficial level of exploring someone's thoughts and feelings and be delivering some of these acceptance and commitment tools and strategies. But if there is a deeper level that needs to be explored, then that's when we would bring our psychological therapists in, and they're all in-house, so it's not that we would outsource to another service. They're all part of the same team, and we communicate a lot, and just deliver a really consistent message around that. And then I think the other key piece of that is a lot of self-compassion. So it's sort of like, it is really difficult, it's really, really hard to be experiencing these symptoms every day, and if we can help people to develop some of those skills as well, it can take the sort of the pressure off themselves that they put on themselves, but also we're kind of walking alongside our patients rather than us trying to be the ones to provide a fix as well, if that makes sense. How's that? Anything else that I've missed?
I don't think so. Yeah, just to add, just to manage the patient's expectations as well. So right from the beginning, when they're first referred, just managing their expectation, what the service can provide and what is a little bit out of our remit, and what we would do to help still, and encourage onward referrals, etc. So yeah.
Thanks, Patrick. Great question. So it looks like we're at time. So thank you everybody for coming and listening, and there will be a recording after this, and do share with colleagues, and make sure everybody knows that these services are still running, and please do refer anybody that you see that you suspect may be experiencing fallout from COVID. So Da, anything else to add at the end?
No, thank you very much. Thank you. And have a great day, everyone.
Lovely. Take care, everybody.
Take care. Thank you.
Bye.
Bye-bye.
Bye.